record. And if I have other people hop on, I will do that. And so Kathy will, Loretta, do you want to introduce yourself just so Kathy knows who you are? I think your role is unique and interesting.
Absolutely. Yeah, my name is Loretta Mize. I'm the Adult Guardianship Coordinator with Thrive Alliance. I've been in this position for a little over 2 years, and I work with adults, mostly adults with disabilities and senior citizens that have been deemed incapacitated and need advocates for themselves.
Huh. Sounds like very valuable and interesting work.
It is very valuable. It can be very, very interesting. We have a lot of different experiences that we deal with, and so I thought this seemed interesting because the diabetes and disability is something that I deal with quite a few of my clients. So
okay, good.
Awesome. Okay. Well, thank you, Loretta. And so, Dr. Auberry, I'll let you introduce yourself when we start.
Okay.
I'll have to do it twice. Okay, so we are recording. I'll edit this. So I'm going to go ahead. Here we go. Okay, so I'll go ahead and make it live so everyone knows that's happening. Takes a moment. Okay, welcome to one of our presentations this month for Disability Awareness Month. We are lucky to have with us Dr. Kathy Auberry, who's going to present a little bit about diabetes and disabilities and the intersection of that. In this conversation, if you are on the call or listening in on Facebook or watching the recording, is for individuals themselves with disabilities, parents, guardians, direct support people, or even individuals in the medical field. And so there will be something for everyone to take away, and we are excited to share this with you all. So without further ado, I'd like to introduce Dr. Kathy Auberry.
All right, well, thank you, Grace. Thank you very much. Move here. Hold on just a second. We're sticking just a little bit.
No worries. As I say,
I apologize.
2 years into the pandemic, there we go.
There we go. I apologize if that happens from time to time. I live kind of out in the country, so sometimes that happens, but thank you, Grace. Just a little bit of background about myself. I've been in the field of intellectual and developmental disabilities for about 26 years now. I started out as a direct care nurse and then director of health services and director of operations for a nonprofit that supported people with disabilities and complex healthcare needs. And I did that for about 18 years. Then I went on to become a professor at IU School of Nursing in the Columbus campus. And I did that for, again, about 10 years. Currently, I am an independent consultant working in the field of developmental disabilities, and also a fellow mentor for the Golisano Institute for Developmental Disabilities Nursing. So we are helping nurses become more knowledgeable about the healthcare needs of people with disabilities. So I'm really happy to be doing that. So it's been an interesting career, and I am very happy to be here with you today. I want to thank the Arc of Bartholomew County, especially Grace Kessler, the executive director, for this opportunity to share some information with all of you today. So thank you very much for this opportunity. Kind of give an overview of what we'll be doing and going over today. We'll have a session on diabetes in persons with intellectual and/or developmental disability. We'll define type 1 and type 2 diabetes. We'll discuss hyperglycemia and hypoglycemia. We'll look at some treatment options for diabetes. We'll look at administering insulin with an insulin pen. We'll talk about self-care and also educating and supporting people with diabetes. We'll look at some prevention strategies, and we'll also discuss a little bit about when we need to seek help. Our objectives for today is to understand the basic physiology of diabetes, to define diabetes, to identify risk factors for individuals with intellectual and/or developmental disability and developing diabetes, to be able to name the normal range for blood sugar readings, to identify the signs and symptoms of high blood sugar, also known as hyperglycemia, and also the signs and symptoms of low blood sugar, known as hypoglycemia. Further objectives: recognize treatment options for high blood sugar and to recognize treatment options for low blood sugar, to describe how to accurately complete a blood sugar check, label the steps for administering insulin using an insulin pen, list some self-care tips to follow, and then lastly, identify when to seek support. So just a clarification, diabetes management, including blood sugar checks, oral medications, injectable insulin, and insulin pen administration should always be under the continual guidance of the primary care provider and/or agency nurse. Guidance should include specific medication and insulin orders, schedule of blood sugar checks, training, and a treatment plan for both high blood sugar and low blood sugar reactions. The following information is for background and educational information only, and it's not intended to prepare self-advocates, family members, or DSPs to perform blood sugar checks, administer oral medications, or give insulin injections, and is not considered to be comprehensive in content. So it's just kind of like a beginning educational presentation for you today. So to begin the first session, we're going to talk about diabetes in persons with disability. Currently, aging population with age-related disorders such as diabetes. We know that over the past few decades, healthcare professionals have become better about understanding the healthcare needs of people with disabilities, but we still have a long way to go. Because we've made some of these advancements, a lot of people with disabilities are living longer lives than they have ever before, and that is wonderful. But also with that, there are age-related disorders such as diabetes that have now surfaced and becoming more prevalent in this population. There's also some classes of medication that are used often in the field of disability that may increase the chance for people to develop diabetes. An example of this would be antipsychotic medications. Antipsychotics may lead to a weight increase for the person that's using them, and any weight increase can be a precursor to developing diabetes. There are other medication classes as well. There are some antidepressants that also have this same potential to be a precursor to people developing diabetes. There's still an inadequate focus on disease prevention for people with disabilities. Again, as I said, we have made advances in this over the last couple of decades, but there's still not the focus on disease prevention that there needs to be for people with disabilities. Another possible contributing factor to an increase in the diabetes in this population is a sedentary lifestyle, or one where all of us are guilty of from time to time, not getting up and moving, not having enough physical activity. And the same is true for people with disabilities. Sometimes we just need to encourage more exercise, more physical activity where we're getting up and moving and not having such a sedentary lifestyle. There also might be physical limitations for some individuals with disability that may increase their chances of obesity just because they cannot do some of the physical activity that would help keep their weight under control. Again, some people with disabilities are less likely to have the adequate health checks they need, to have screening for diabetes early on when it's maybe in the pre-diabetes realm instead of waiting until it is full-blown diabetes. There's also risk for type 1 diabetes and certain types of syndromes that can be prevalent in people with disabilities. Klinefelter syndrome, for example, or Prader-Willi and Down syndrome all have a potential to increase weight. there's a lot of research around not only people with disabilities, but just in the general population, that the larger extra weight around the stomach area, or what's known as the girth, has been identified as a contributing factor to insulin resistance. And that insulin resistance can help bring on the diabetes diagnoses. And so we're really concerned about weight, and when it's contributing and mostly distributed around the waistline, that has been researched and identified as a possible risk factor to insulin resistance, which can lead again to diabetes. So let's talk about prevalence of diabetes. According to the Center for Disease Control, this research was out of 2018, about 1 in 6 people with disabilities, or 16.7% in the United States, are diagnosed with diabetes. When you compare that to people without disabilities, it's only 1 in 14, or about 7.4%. So you can see that it's a little over 2 times more prevalent in people with disabilities than in people without disabilities. So it is a significant issue that we need to pay attention to. So throughout the presentation, I'm going to have what's called a comprehension checkpoint. And that is just for a chance for us to go back over some material that's kind of important for us to remember. So what are 3 risk factors for individuals with intellectual and developmental disability in developing diabetes? So we're going to revisit that. And then we're going to revisit, according to research by the CDC, what is the % of individuals with disability who develop diabetes? And so if we move forward and answer those questions, the risk factors for developing diabetes, if you have also a disability, is the fact that it is, an aging population. The use of many different classes of medications can also contribute to developing diabetes. The sedentary lifestyle, or not being able to get the physical activity that's needed, and the limited focus on prevention. And then also, what is the % of individuals with disability who develop diabetes? According to the CDC in 2018, 1 in 6 people with disabilities, or 16.7%, will actually develop diabetes. So let's define diabetes. There are several different definitions. This is one that I really like because I think it's just really down to earth and easy to understand. It says a condition in which the pancreas no longer produces enough insulin, or cells stop responding to the insulin produced, so that glucose in the blood cannot be absorbed into the cells of the body. So we all know that the glucose must go into the cells of the body to produce the energy and to help the body function the way that it needs to. If you look on your screen in the very top box where it says normal on your screen, you see the pancreas there. The pancreas is the organ that produces the insulin. And if you follow the green arrow around there, it shows you that the pancreas produces the insulin. It goes over to the insulin receptor and enters into the cell, the body cell. And that's the normal way. That's the way it's supposed to work. If you look at the box in the middle there, this is type 1 diabetes, and we'll define type 1 and type 2 in a little more detail in just a moment. But with type 1, there's a destruction of what's called the B cells in the pancreas. So it is unable to produce the insulin that's needed. And so the insulin receptor, the little square over there where the green is at, shows you that the insulin receptor is okay and the insulin could go into the cell, but there's no insulin, or not enough insulin to go in to help the body function the way it's supposed to. And then the last box at the bottom where it says type 2 diabetes. With type 2 diabetes, the pancreas may produce insulin, but as you can see, when you swing it over into the little box where it's got the red X there, the cells become insulin resistant. And this is the more popular kind as we age. This is the type 2 diabetes that is more apparent in people as we age. So the body becomes resistant. Remember when I talked about the girth a minute ago about the stomach, when you have too much weight around your stomach area and the body becomes insulin resistant? This is what I was referring to. So the insulin is produced by the pancreas, at least to some degree, but the body no longer receives that insulin the way it should. And so again, it builds up in the bloodstream, and then you have the high sugar in the bloodstream and not in the body cells where you need it to be able for your body to function correctly. So let's talk a little bit more about some of the differences between type 1 and type 2 diabetes. Type 1 diabetes, again, your pancreas doesn't make insulin, or again, makes very little insulin, not enough for your body to function. As a reminder, insulin is a hormone that helps blood sugar enter the cells in your body where it can be used for energy. Without insulin, blood sugar can't get into the cells and it builds up again in the bloodstream. Type 2 diabetes is a condition in which the cells cannot use blood sugar efficiently to meet the body's needs. So again, the pancreas may be producing the insulin, but the body is not able to use it correctly. So if we compare a little bit type 1 diabetes and type 2 diabetes, you can look on the screen there. On the left-hand side of your screen is type 1 in the green. On the right-hand side of your screen is type 2 in the green area. And in the center of the two circles in the white area are the things that they have in common. So let's start with the type 1 on the left side of your screen. It cannot be prevented or cured. Type 1 diabetes used to be called juvenile diabetes. It more often is identified early on in a person's life. Again, the body does not create enough insulin. The causes are unknown, but it's believed that genetics may play a role in the development of type 1 diabetes. And it does require insulin injections for life. So these folks are dependent on insulin to control their type 1 diabetes. If you look on the right side of your screen on the type 2 diabetes, it says can be prevented through lifestyle modifications. And that's why it's so important to understand that, understand about weight maintenance, understand about carbohydrate monitoring, monitoring sugar intake, because we can, to some degree, either prevent it or maintain a healthy blood sugar by the things that we actually do. And that's the positive side about type 2 diabetes. The body does not create enough insulin or develops, again, that insulin resistant that we talked about earlier. Causes include genetics, aging, inactivity, obesity, and then there's some other causes as well. Type 2 diabetes requires insulin as needed, injected, or also oral medications can be taken, or sometimes a combination of the two. If we look in the center there where the white, this is where type 1 and type 2 overlap. Both can cause other serious health problems and complications. That's one reason it's so important that we control our diabetes if we have that diagnosis. It requires both of them a healthy lifestyle and medical supervision to keep it under control. Both include symptoms of thirst, frequent urination, and blurry vision. So you can see that they overlap in a lot of important areas. So again, let's look at the signs and symptoms of diabetes. The first one is frequent urination, going to the bathroom a lot. Lethargy or feeling tired, just not feeling like yourself. If you look at the picture there, the little guy on the screen with the coffee and it says good morning, and he's not looking like it's a good morning. That's kind of a very good visual of lethargy, just tired, not feeling quite like yourself. And then excessive thirst. And so it's kind of a circular, never-ending pattern. You have excessive thirst, you have frequent urination, and it just keeps circling around. And then hunger, feeling hungry. Even if you are eating regularly, you're still feeling hungry. Cuts and bruises that are slow to heal could also be an indication. Weight loss, even though you are eating more, is one of the signs of a type 1 diabetes. And then tingling, pain, or numbness in the hands or feet can also be indicative of type 2 diabetes. So I hope those photos there kind of help. Sometimes pictures are better than words, and just thinking about going to the bathroom, feeling tired, drinking too much, and being hungry are all signs and symptoms that we need to pay attention to. So let's talk about hyperglycemia, or too much sugar in the blood. So the causes sometimes can be that there's diabetes and it's just been undiagnosed. It's not been diagnosed yet. Infections, especially for individuals who have been diagnosed with diabetes, anytime you have an infection in your body, it will also increase the blood sugar levels in your body. So it's always important to remember that blood sugars usually go up when there's some kind of an infection going on. Some medications can also increase blood sugar, and emotional stress. So a lot of things that interfere with our daily routine and how our body works, if those are thrown off a little bit, oftentimes those can include or increase the blood sugar in our bodies. Again, the symptoms: increased thirst, increased urination, some vision problems, that blurred vision that we talked about earlier, and fatigue. Treatment options for hyperglycemia: a lot of times, if it's mild hyperglycemia, can be, again, controlled with diet and exercise. If not, then we have oral agents, medications that are taken, and also sometimes insulin. And sometimes a combination of those two are needed to control for a lot of people. So hypoglycemia, or too low of sugar, this is also something we have to be aware of. Causes can be an overdose of insulin. So if it's an individual who is taking insulin, either for type 1 or type 2, and they have too much insulin, then that can cause the blood sugar to go too low. Insufficient diet, over exercise, someone who's exercising too much can also cause the blood sugar to go low. Some treatment options at times for this: 4 ounces of orange juice can help, a little bit of honey, 4 to 6 ounces of milk, a teaspoon of peanut butter, an ounce of cheese. These are options and can be used. What's important is to know each individual person, whether it's you as a self-advocate, if you're a DSP, caring for someone, what's in that person's plan? What should they be doing? What was decided was the best for them if their sugar got too low at some particular point? So these are just some suggestions and things that can be added to plans that either a team or health professional has put together for you. Symptoms of too low blood sugar can be fatigue, pale skin, shakiness, anxiety, sweating, hunger, and irritability. And you will find these pretty consistent for folks who have diabetes and their blood sugars went too low. The irritability, shaking, hunger, sweating, very common when the blood sugar goes too low. There's one more condition that I just like to briefly mention, and that is called Diabetic Ketoacidosis, or DKA. This is a condition of type 1 diabetes when left untreated. So DKA can progress if type 1 diabetes is not managed well. So it occurs when blood glucose is dangerously high and the body can't get nutrients into the cell because of the absence of the insulin. So if you go back and think about the insulin trying to go in those cells that we had in the pictures earlier, when that doesn't happen, then the body starts breaking down muscle and fat for energy. And this causes an accumulation of what's called ketones in the blood and the urine. The symptoms of DKA include a fruity odor on the breath. So when you smell the breath of the person, it smells very fruity, kind of like fruit gum. Heavy taxed breathing might be present, and also vomiting might be present. If it's left untreated, DKA can result in stupor, unconsciousness, and even death if the person is not treated. So I just wanted you to be a little bit aware of what type 1 diabetes, if left untreated or managed poorly, can develop into. So just a little bit of a caution on DKA. So we're back to a comprehension checkpoint. So what are symptoms of hyperglycemia and what are symptoms of hypoglycemia? So there on your screen, hyperglycemia, increased thirst, increased urination, vision problems, and fatigue are common. And then for hypoglycemia, fatigue, pale skin, shakiness, anxiety, sweating, hunger, and irritability. So let's move on and talk about screening first off for diabetes. How do we screen for diabetes? And then second, monitoring. How do we monitor for diabetes? So the first test we're going to talk about is called a fasting blood sugar, or FBS. This test checks fasting blood sugar levels. Fasting means that the person has not had anything to eat or drink except maybe a little bit of water for at least 8 hours before this test. So this is a blood test, usually done first thing in the morning before breakfast, 8 hours since the person has had anything to eat or drink. So normal, if you look at the little chart there on the screen, normal most of the time is considered less than 100 milligrams per deciliter to be a normal fasting blood sugar. If we look at someone in the pre-diabetes range, this may be 100 milligrams per deciliter to 125 milligrams per deciliter. And we talked earlier about pre-screening individuals and how we're still not at the point that we need to be to making sure we're screening individuals with disabilities for different conditions. So you can see where we could catch someone in a pre-diabetic condition just by this fasting blood sugar test. So there are many conditions and the medications, like we talked about before, where having a fasting blood sugar on a routine basis might be advisable for a lot of people. And then the diabetes section there, 126 milligrams per deciliter or higher. You will see these ranges, depending on the lab that you're participating in, may be a little bit different. So this is just an average of what you will see most often, but they could be 1 or 2 numbers higher or lower depending on your lab. Usually one fasting blood sugar does not diagnose diabetes. Usually follow-up tests are done, but this does give you an idea of what we're talking about for a fasting blood sugar and what the normal pre-diabetic and the diabetes determination might be. The other blood draw that is common for people diagnosed with diabetes is what's called an A1C, or a glycosylated hemoglobin. And this blood draw, you do not have to be fasting for this one. It's an average blood sugar over the past 2 to 3 months. So if you think of an average test score over the last 2 or 3 months, or a baseball score and what an average is, that's what this test does. It actually looks at what your average blood sugar was running over the previous 2 to 3 months before you had this blood draw. So it also can diagnose prediabetes. It monitors diabetes, so people who have been diagnosed as diabetic, this lets them know kind of what kind of control they have over their diabetes. So if an A1C level is between 5.7 and less than 6.5%, levels are considered to be in the pre-diabetic range. So again, we can look at someone and say, oh, they're getting close. You know, what can we do for this person to be able to maybe control this with diet and exercise? If the A1C level of 6.5% or higher, levels are in the diabetes range. And again, these numbers might alter a little bit depending on your primary care provider and the lab that you use, but this is a pretty good average of what we look at as far as testing. So again, this is the A1C blood draw that looks at your average blood sugar over the previous 2 to 3 months. So our comprehension checkpoint. What is the difference between the blood tests, A1C, the glycosylated hemoglobin, and the fasting blood sugar? So the fasting blood sugar, remember, nothing to eat or drink for 8 hours, and it tests your current blood sugar level that morning. What was your fasting blood sugar level that morning? The A1C is the average blood sugar over the previous 2 to 3 months before you had that test taken. So most providers will use both of these to help monitor, not only diagnose, but also to monitor your blood sugar control once you've been identified as diabetic. So here's just a few steps. If we have some self-advocates who test their own blood sugars in the audience, if we have some DSPs or family members, these are just some really common steps to taking a blood sugar test to be able to prick your finger and check your blood sugar on a routine basis. It is important to always read all of the instructions that come with your glucometer, the meter that you have. There are a lot of different models out there, so you want to make sure that you have read that one very closely. You understand how to use the different devices because, as I said, there are a lot of different ones out there. But these are some very basic steps that you'll want to always to abide by. So the materials that are needed, of course, are a glucometer, the lancets, or the what you prick the finger with, test strips, and alcohol swabs. You want to make sure and wash your hands thoroughly before you start. You want to use an alcohol wipe to cleanse the finger to be tested. It also helps if you kind of shake your hand down a little bit, or the person's hand that you're going to be testing, just to help the blood flow come down a little bit to the fingertip. Once you alcohol that finger, cleanse it, you want to make sure and let that site dry before you continue with the testing. You want to place a testing strip into the meter. Then prick the side of the finger with the lancet to get a small drop of blood. The blood goes on the test strip and then inserted into the glucometer. The monitor will analyze the blood and give you the blood glucose reading on its digital display, usually within a minute. And actually some of the newer ones, it's almost instantaneous, so you get a very quick reading. These finger pricks rarely require a Band-Aid, but you may want to use one if the bleeding continues. If you have someone who is on a blood thinner, of course, then you probably may want to watch that bleeding a little longer, a little closer, and may need to cover that with a bandage. And again, it's important to follow all the instructions that came with the particular glucometer that you are using. So let's talk a little bit now about treatment for diabetes. Weight loss and a healthy diet. So I've mentioned that several times today because I think that is so important, either at the prevention end of things, or if a person is in the pre-diabetic stage. Many times we can help reduce the risk of developing diabetes with weight loss and a healthy diet. So you may want to get the help of a nutritionist or a dietitian to help you develop a healthy weight loss diet, to be able to eat the proper foods, to be able to read labels, to know what is in the foods that you're eating. There's a lot of things that go around looking at a healthy diet and looking to lose a little bit of weight so that we can keep those blood sugars under control. Exercise, of course, you always want to make sure and clear with your primary care provider before you engage in any exercise program. But exercise is so important in keeping blood sugar levels consistent and where they need to be. We all need positive emotional support when we are trying to keep blood sugars under control, to have a healthy diet plan, or engage in an exercise program. So we all want to have those positive emotional support people and programs around us. Of course, oral medications are very important. You know, if we've tried the diet and weight loss and exercise program, but maybe our genetics are not responding to that the way we had hoped, then of course we may have to also include oral medications. If it's a type 1 diabetes, of course, insulin. With type 2 diabetes, it may be a combination of both oral medications and insulin to help keep our blood sugar levels consistent and where they need to be. If we look at oral medications, there's a great many different types of oral medications to help control blood sugars out there. There's what we call first generation and second generations listed there on your slide. Just to list a few that you might be familiar with. There's diabinase, tolinase, orinase. These are all very common first generation blood sugar agents. Second generation, micronase, glucotrol, very common also. Prandin, Starlix are a little bit newer types of oral agents. There's glucophage, Actos, Avandia, Precos. All of these are medications that you may have heard the trade names for to help control diabetes and keep our blood sugar in control. And new ones are being developed all the time. We do also, of course, mention taking medications without looking also at the side effects, because we're always looking at balancing the benefits of a medication we take with the side effects that may happen. They may not happen, but we need to be aware of them. So I have some of them listed up here, but I will say what's most important, whether you're a self-advocate for yourself or you're a DSP or a family member, you want to know the side effects of the oral agents that you're either taking yourself or you are helping administer to someone else. But some common ones to look at here. Low blood sugars, very common with sulfonylureas, upset stomach, skin rash, itching, weight gain are very common. With something like metformin, alcohol does not mix well with these drugs, and that's very important to know. There sometimes can be kidney complications, upset stomach, tiredness or dizziness, and some of these medications also leave a metal tasting sometimes in the mouth, so that's something to be aware of. And then the inhibitors there at the bottom, gas, bloating, and diarrhea can also occur. So this is just to let you know that, we do want to always monitor not only the benefits of the oral agents, the oral medications we're taking, but also to be aware of those side effects and make sure that we're also monitoring for those as well. Also, insulin is very common way to help control diabetes. It's crucial in type 1 diabetes. We're seeing it used more now in conjunction with oral medications, also in type 2 diabetes. There's various insulin types. There's what we call the action of the insulin. There's some that react in long term. So some insulins will be in the body and consistently help lower blood sugar for 8, 10, 12 hours, depending on what type of insulin it is. There are some short-acting insulins that are made to be used in between that may only have a 2-hour window of effectiveness. So there are a lot of different types of insulin that are used to help control diabetes for different folks who have different needs as far as controlling their diabetes. Accurate measurement of insulin, I cannot emphasize this enough, that is crucial, that when you're responsible for administering insulin, either to yourself or someone else, make sure that you have an accurate measurement for that insulin. There are what we call sliding scale orders, and I'll show you an example of one here in a minute. And a sliding scale order is just someone will take their blood sugar. Let's say they take their fasting blood sugar in the morning with their finger prick, and it falls within a certain area. Then they can go to a scale that a health professional has developed for them, and it'll tell them how much insulin to give themselves that morning, or how much insulin a DSP or a family member will give the person who needs the insulin. And it's just a way to help manage insulin a little bit better and manage that blood sugar level a little bit better. There's also, syringe type, where you have more of the old-fashioned type, where you have a bottle of insulin and the syringe that you pull up. There's also the pen options, which have been wonderful to use. They're much easier to use. Most anyone can learn how to use an insulin pen. You always want to make sure that you know what the storage of your insulin, whether it's the old-fashioned bottle and syringe or it's the insulin pen. You need to know what the storage, so you want to make sure and always read all the paperwork that comes with insulin. If you're working for an agency, then what is the agency policy for insulin administration? And is there a protocol that you are supposed to be following for that? So just some tips on insulin. For the insulin pen, you want to make sure and use the correct needle size when you are administering and using insulin, administering insulin with an insulin pen. And that usually comes as an order from primary care provider. So using that correct needle size is important. And then also remembering that you only use a needle once, and then that is disposed into a sharps container, and you get a fresh insulin needle every time that you administer insulin. There are multiple types of pens available, insulin type pens. So you want to make sure that you are trained and use the correct one that you are trained for. And I'm going to try here to, we have a very short little video, see if I can pop it up for you so that it's a very short, it's just about 2.5 minutes, and it just goes through some basic understanding about insulin pens. Now this shows one type of an insulin pen, but as I said before, there are various types, so you would really want to be familiar with the type that you're going to be given. See if I can get this to pop up here. It did earlier, so hopefully it will.
Sometimes if you minimize out or control click.
Yeah, I tried to control click, but it wasn't. Let me try one more time. And if it doesn't go through, if you go to YouTube, they have a whole variety of different types of videos that show the different types of insulin pens that you can go to. It's not coming through for me. I apologize. I don't think it's going to pull up. Maybe we could try at the very end again. I can minimize and see if that will work. But right now it is not popping up for me.
Okay, we can always send out the link in the follow-up as well.
Okay, that would be great. Thank you. So here's the old-fashioned type of insulin. It does still, especially if someone has very hard to control diabetes, you will see insulin used more of this type of diabetes management with the old-fashioned bottles and syringes, mostly used to treat type 1, but also sometimes now type 2 as well. And you see the different types listed there. Humulin, which is considered an intermediate acting insulin. So it's going to be somewhere between your short acting and your long acting. There's Atlantis, which is considered long acting. It's usually injected 1 time per day, the same time each day. There's Humalog, which is a rapid acting insulin, and Novolog, which is also a rapid acting insulin. So again, thinking about these and the side effects, one of the things you always want to be thinking about when you're giving insulin is maybe that the insulin has caused the person's sugar to go too low. So that's when you want to be watching for those hypoglycemic reactions, the sweating, nervousness, irritability that we talked about earlier. But talking about insulin and the insulin type, there's a lot of caution with this. There really needs to be comprehensive training by a medical professional with hands-on and return demonstration by the DSP, if you're the one. If you're a self-advocate and you're giving your own, make sure that you feel really comfortable with the training that you received and you feel comfortable giving yourself that insulin. You have the right to make sure that it's thoroughly explained to you and you have lots of opportunity to practice. You want to make sure that you have a healthcare provider's order for the type of insulin and the amount and when to give it. Make sure that there's also a healthcare diabetes plan as part of this. If you're a DSP and you're working in an agency, you want to make sure there's an approval that there's a policy in place by the agency that allows you as the DSP or the self-advocacy person to be able to administer this insulin, to make sure that you have the right syringe. TB syringes and insulin syringes look very much alike, but they are measured very differently. So you want to make sure that you have the right syringe. That accurate administration that I talked about before is really, really important. So in nursing school, we always learn to do a two-person check. So one person draws it up, you have a colleague look at it and say, this is what's supposed to be, is this what I have measured up? So it's just a safety tip that I have always passed on through all the years, is to have that insulin double checked. It's always a safer thing to do. And just to make sure that you have some other person say, yes, that's the right amount. So our next comprehension checkpoint, true or false? There is only one type of insulin to treat diabetes mellitus. And of course, that's false. We went through all the different types. There are many types of insulin, short-acting, long-acting, intermediate, and different variations of those insulins as well. So a lot of different options out there to choose from. So when we talk about injecting insulin, whether we're talking about the more old-fashioned pen or needle and bottle, or we're talking about the insulin pens, it's also important not only to measure it up correctly, but also to make sure that we give it correctly. If we're giving it to ourselves as a self-advocate, or if we're a DSP or family member, we want to make sure that we're giving it correctly. And so insulin is given by a method called a sub-Q injection, which just means that we want it to go into the subcutaneous tissue of the body. That's where it's absorbed the best. And so to do that, a 45-degree angle, and if you look on your screen there, it kind of shows you where that 45-degree angle is. Really important to get it in there, in that subcutaneous tissue. To do that, it's also really good that you take your fingers and you pinch up the skin a little bit. And if you see that bottom picture there, it shows you that yellow tissue there, that's the subcutaneous tissue. That's where you want the insulin to go in, right there. So we pinch up the skin, we go at a 45-degree angle, and then either with a pen or a syringe, then we're going to slowly inject that insulin into the subcutaneous tissue. And once the needle's in there, it's always a good idea, just once you've pushed it in, maybe to count 1, 2, 3, 4, 5. Release the skin, withdraw the pen or the syringe that you have used. So that's where we want that insulin to go. Another thing to think about is the injection sites. You know, where can we find the subcutaneous tissue? Where is it the easiest to give? And this diagram shows you some of the sites, because you, again, want that to go into the subcutaneous tissue. There on the body, you can see where it's kind of marked on one thigh and the other thigh. And then all around the belly button is also a really good place to give insulin injections. You can also do it on the subcutaneous, kind of the back arm on either of your arms as well. All good places to pinch up that skin and give it at a 45-degree angle. Another thing that's really important is to rotate the sites. And that's why you see it says Monday, Tuesday, Wednesday, Thursday, Friday, Saturday. You want to alternate the sites that you inject the insulin, because you don't want to give it in the same spot all the time. Doing that can cause the skin to become tougher, kind of calloused. And if you do that, then the distribution, the way the insulin goes into the body, gets interrupted and is not dispersed the way we want it to be. So rotating those sites prevents that buildup, that callus of the skin. And then also, we talked a little bit earlier about a sliding scale, and those are standing orders that are determined by the blood sugar readings of that particular person. So this is a sample of a sliding scale. There are many different ways to do a sliding scale. It used to be very common to have sliding scales. They're not quite as common as they used to be, but you do still see them used a lot. If you look over in the very left side, where in green up at the top, it says finger stick blood glucose. So you see that's where it has a range. It has a range of, so someone that morning would take their blood sugar, and let's say it was between 60 to 150. If you go over to the first section where it says a mild scale, so this would be somebody who doesn't need an aggressive protocol in place, it says no insulin. For 151 to 200, it says you would not give any insulin. And then it goes to 201 to 250, and it says if your fasting blood sugar was between 201 or 250 that morning, you would give yourself 2 units of insulin, or you would administer to the person that you're responsible for 2 units of insulin. So this is just an example of what you might also see or come across. And as I said, there are many different variations and formats of sliding scales, but this is just one way to help keep better control over day-to-day consistent blood sugars. And so that's called a sliding scale. It's worth mentioning also, and these are becoming more popular, just as is an insulin pump, which regulates the amount of insulin going into the person's body all the time. So you might see these in use also. And also on commercials now, you might have seen where instead of having to prick your finger all the time, they've come out with these new devices where your phone reads your blood sugar for you. I mean, all those are just advancements that are wonderful to see. Anytime we don't have to stick somebody more, I think is wonderful. And this insulin pump also works just really well for people who have a really hard time controlling their blood sugar levels. Just to remember, for high blood sugars or hyperglycemia, want to make sure and follow the plan that the healthcare provider and or the support team has put into place. It's always important to make sure that everybody on the family and the team understands what the healthcare plan is in relation to diabetes. And the same for low blood sugar or hypoglycemia, is to know those differences. Hypoglycemia can be every bit as dangerous as hyperglycemia. I've seen folks look like they were having a stroke, a CVA, because their blood sugar was too low, and it really resembled a stroke. And what it really was somebody's blood sugar being too low. So always make sure that you understand those pieces about the healthcare teams, the plan for monitoring and caring for the person with diabetes. So to talk a little bit just about self-care, educating and supporting, one of the things that you need to do is make sure you keep your feet happy. A lot of times what happens is injury to the feet causes a whole host of problems to come up in someone who's been diagnosed with diabetes. So if you're a self-advocate, you want to make sure and check your feet every day. Make sure there's no open areas on them, dry skin areas. If there are, you want to make sure that those are treated well. You want to wash your feet every day, and then you want to dry them really well. Make sure that they get thoroughly dried before you put socks or shoes on. And then also to wear shoes that fit good. If you're a DSP, you want to do the same thing for the people that you're supporting. You know, that should be part of the daily routine, having people check their feet, make sure that there's no skin openings, no areas, calluses, things that can develop into sores that are very, very difficult to treat in people with diabetes. Also is to take care of your eyes. Diabetes, especially over time, actually damages the little bits, the little arteries and vessels in the back of your eyes, and it damages those, and then your eyes vision becomes very blurry. You can't undo the damage that's done once it's done. And so regular eye checkups with whatever your ophthalmologist deems necessary is important. Reporting problems with your eyes is really important. Having those regular checkups, but then also knowing, you know, I'm not seeing very good. Maybe there's something else I need to go sooner is really important. So also make sure that eyes are very well taken care of, because as I said, once the damage is done, then there's no going back for that. Eating healthy foods, vegetables, drinking good fluids, reading labels, very, very important. When I was working directly in the field, we would have lessons on reading labels, reading can labels, package labels, all all kinds of information you can find on labels, and the amount of glucose or carbohydrates on a label, very important. Some foods that we would not think would be high in sugar are really high in sugar. So making sure that we're eating healthy. And as I said previously, maybe having a dietitian or nutrition, somebody helping you put together a healthy diet plan. I'm not calling it a diet necessarily, just healthy eating, making sure it's healthy eating. So as DSPs, families, and self-advocates, we can help reduce the risks associated with diabetes. We can help educate using information about diabetes that's in a format that's appropriate to our audience. So using pictures or interactive times that make it approachable and understandable to whoever our audience is. To make sure that we educate on the risk factors for developing type 2 diabetes. You know, we went through a lot of that, inactivity, obesity, those types of things, some medications, all of those things. You know, what are the risk factors for developing type 2 diabetes? And then assist people to modify their lifestyle and their behaviors to a more healthy lifestyle so that we can intervene prior to diabetes or even in that pre-diabetic stage, where we can use diet, exercise to help that person from developing diabetes. To be able to create with the team and the individual a diabetes health action plan that is right for that person. It's not one size fits all. You know, we've given a lot of general information here today, but it is definitely not one size fits all. You know, we need to look at that person, you know, their, if you're a self-advocate, you know, what do you want? You know, what is your desire for your life? And, you know, what are the challenges that you face? What are the things you want to accomplish? All those go into creating a diabetic health action plan that's right for each person. And to set realistic goals. If we set goals that are not attainable, then nobody's going to stay with that diabetes plan. So we want to set realistic goals. And then we all need a strong focus on celebrating and positive support. So when a goal is reached, whatever those realistic goals that we've set for our blood sugar or our weight loss related to managing our diabetes, then we need to have a celebration for when we accomplish those goals and have positive people around us to help keep us on the right track to managing our diabetes. Very important that we have that positive support around us. So preventing diabetes. Again, we've talked a lot about obesity, but that is just such a significant contributor to the development of especially type 2 diabetes. So we need to reduce obesity. How do we do that safely and in a way that people do not get frustrated? Diet control. We need to reduce sugar intake. So reduce fats and saturated food intakes. Maybe eat smaller portions of the starchy carbohydrate foods such as potatoes, rice, and bread. You know, I mentioned earlier that carbohydrates or the sugar foods are present in things that we don't necessarily think about. And so we need to read those labels so we know what those things are. And promote activity. Again, all of this is designed to keep our weight at a good level and to reduce the amount of sugar we take along with that diet control. So all of these things help prevent diabetes. They also help maintain once we get to the level of blood sugar that is healthy. So individualized diabetes plans, so things to think about, whether you're your own self-advocate and you're trying to put together something for yourself, or you're a DSP or a family member, and we want to put together a plan that's realistic for that person. So some things to think about when you're putting together that diabetes plan. It should be developed with a person that has a diabetes and whatever their support team is, whether it's family members, whether it's agency personnel, that person with the diabetes has to be included in that plan. It's the only way that that plan will work. You want to include a sick day plan. If you remember, we talked earlier about blood sugars increase during times of illness, right? We talked about infection, even just a cold, the flu, COVID-19, all of those things increase the risk for the blood sugar to go up. What's tricky about that is a lot of times during those times, then people don't eat either. So you have to be really careful. You have to monitor the blood sugar. You may have to alter the amount of insulin or oral medication that that person gets that day. So with the help of the team and your primary care provider, you can put together a sick day plan that will meet the needs of that person. It may include a sliding scale, especially for those sick days. I think a sliding scale works really well because you may be actually reducing the amount of insulin you give, just depending on whether or not that person has eaten that day. So that can be a really good part of that. As we talked about before, monitoring skin and feet. We talked about the feet a lot, but you really want to monitor all of the skin because any break in the skin is a potential for infection to set in, which again can increase blood sugars. You want to make sure that you have a tracking sheet for monitoring blood sugar levels. So we want to make sure that you keep a consistent blood sugar record. A lot of those glucometers that we talked about before actually track those for you, which is really nice. You can go back and see what blood sugars were, but sometimes it's also nice just to track them on a piece of paper because you can kind of see in one glance what blood sugars have been for you, or maybe the time of day. If you're somebody that has to take your blood sugar several times a day, you can see when it's higher, when it's lower, and then be able to take that with you to your primary care physician and see if any adjustments need to be made. You want to make sure that lab tests are ordered and why those lab tests are ordered. You know, we talked about a fasting blood sugar test. We talked about the A1C that monitors your blood sugar levels. There are other things that healthcare providers, other tests that are also used. So you want to make sure that that's part of the plan also, and to make sure that everybody knows what tests are ordered, when they're ordered, and are they fasting blood sugars? So does a person not need to be eating or drinking prior to that? Making sure that all self-advocates, DSPs, family members are all trained on the diabetes plan that's put together. And sometimes that can be a challenge, especially in agencies where you may have staff turnover, but it's really important that everybody gets trained on the diabetes plan. And also you want to include when to call the nurse if it's within an agency, or when to call for support, whether that's a diabetes educator, it's a primary care provider. You know, when do we know that we need, things aren't working and we need to be able to reach out and ask for help. So all of those things should be included in the individualized person's diabetes plan. So when should we seek assistance? Again, you want to look at the individual person always to make it specific to that person. But in general, as a DSP or a family member, you want to seek assistance if you've not been trained on the individual's diabetes plan and you're put into a new house or home and you're not sure about the diabetes plan, you definitely need to seek assistance. If you've not received training on how to administer the individual's insulin pen, then absolutely, you need to be trained. You also need to do a return demonstration. You need to feel comfortable before you're asked to give that insulin. If you have any questions about the insulin or any medication to control the diabetes that the person has ordered. If signs and symptoms of hyperglycemia or hypoglycemia are present, you definitely need to seek help. You need to call someone, ask for assistance. This is what I see. What do I need to do? Hopefully that's on the individualized care plan, but it never hurts to reach out for help if you need to. If it's stated in the individual support plan for certain things, if the blood sugar is a certain level or a person is showing signs or symptoms of something that might be of concern, then that's a time to seek assistance. And anytime you have concerns about the health and safety of the person that you're responsible for. So just some tips about thinking about diabetes, training on how to administer insulin or the oral medications that you're responsible for. Always make sure that you feel comfortable as a support person to be able to meet the needs of that person. So, comprehension checkpoint. When should a DSP, or if you're a self-advocate, when should you call the nurse or ask for help? So as a reminder, if you have not been trained on the individual's diabetes plan, if you have not received the training on how to administer the individual's insulin pen, if you have questions about the insulin or medication that the individual has ordered, if signs and symptoms of hyperglycemia or hypoglycemia are present, as it's stated in the individual support plan, and anytime you have concerns about the health and safety of the person that you are responsible for. So that concludes my formal part of the presentation. So I've left some few minutes for questions if there are any.
Awesome. I am going to stop the live stream. There we go.